A recent paper caught my eye discussing how we treat our patients with type 2 diabetes to reduce their risk of cardiovascular events. We are all used to data that says we fail to reach our combined targets of A1C, LDL, and blood pressure lowering in patients with diabetes. But a recent paper by Nelson et al. Not only says that we are not reaching our targets, we are not using drugs such as SGLT2 inhibitors and GLP-1 receptor agonists nearly often enough. This multi-center cohort study used health system level data within the National Patient-Centered Clinical Research Network, including 12 health systems. Participants included patients with diabetes and established cardiovascular disease who were seen between January 1st and December 31st, 2018. In terms of their overall findings, only half of these patients were prescribed a statin, and only 27% were on a high-intensity statin. Now remember, all of these patients with type 2 diabetes and established cardiovascular disease should be on a high-intensity statin. So right there, it's pretty disturbing. 45% were on an ACE inhibitor or an ARB, and arguably more should have been on one of those agents. But more disturbingly to me, when it looks at the use of cardiovascular risk modifying agents, only 4% of these patients were on a GLP-1 receptor agonist and 3% on an SGLT2 inhibitor. Now I know these data are from a few years ago, and hopefully things are better, but I think these numbers are incredibly low. And as an endocrinologist, I am always gleeful when I start patients on SGLT2 inhibitors and/or GLP-1 receptor agonists, because I know in my mind I'm helping reduce the complications related to hyperglycemia and reducing macrovascular risk as well. I think that when medications aren't used, there are a variety of reasons. One is obviously lack of knowledge, although hopefully most people are aware of the benefit of these agents. There's issues related to healthcare systems, which include formulary access, the cost of these medications, prior authorizations. There's provider reluctance in terms of using new drugs and patient reluctance to taking new drugs. There can be a lack of knowledge. It may be hard to teach a patient or convince a patient to give an injection. Patients may have side effects, and patients might not really understand the full benefit of these drugs. So there are many reasons why people won't necessarily be on these agents that we all now know are incredibly beneficial. My simplified answer to all of these issues is that as clinicians, we have to be aware of the benefits of these agents and have a willingness to take the time to discuss them with patients. We particularly need to discuss potential side effects and how to deal with them should they occur. I hope that these agents are being used more commonly in 2022 than they were in 2018, but I am not wildly optimistic given the low use of statin therapy in these patients who should be on them. Therefore, we need to be aware of all of the medications we have available for use in our patients with type 2 diabetes and cardiovascular disease, and make sure we treat every patient optimally. Thank you.